My name's Heather Lewis, and as you know, I'm a specialty registrar in gastroenterology. I'm coming to speak to you today because I've just spent the last 3 years doing an MD in viral hepatitis and increasing ascertainment rates. And as part of that, that included screening in primary care migrants for chronic viral hepatitis B and C. So it's something I'm particularly interested in at the moment. What I'm going to want to do today is just to talk to you a little bit about hepatitis B and C, to talk about them specifically relating to migrants, the diagnosis, treatment, long-term outcomes, and then also to focus specifically on screening in migrants in the UK, why we think it's important, and current recommendations and guidelines for screening. Because it's something that's starting to become a lot more, there's a lot more interest in it, particularly in our specialty of hepatology. I'm going to start just by talking you through the epidemiology of hepatitis B and C and why it's so important in migrants. This is from the Centre for Disease Controls in the USA. And when you look at hepatitis B, it's split into high prevalence areas, moderate and low. High prevalence areas are those of over 8%, and they're the green ones, or the dark green on the map. As you can see, this includes most of Africa, large parts of Asia.
Heather, there's a pointer on the...
Oh, I have to work out how to... brilliant. Okay. So as you can see, this includes large parts of Africa and Asia. Moderate prevalence is 2% to 8%, and that includes large parts of the old Soviet Union and also North Africa. And low prevalence includes most of Europe and also most of America. Overall, hepatitis B is thought to have affected 1/3 of the world's population. That's 2 billion people. It's absolutely massive. There are around 350 million people who are thought to be chronically infected with hepatitis B. And in the UK, there's estimated to be around 180,000 people infected, although we don't think we've actually found most of those already. So overall, it's a low prevalence area of 0.3%. In terms of how it's spread, and again, this is important, particularly in migrants, it's usually percutaneous and mucous membrane exposure. I'm sure you all know this, but the important thing is that in high prevalence areas, those areas of over 8%, it's usually transmitted via vertical exposure. So that's from mother to child during childbirth, and that usually means that they'll go on to develop chronic infection. In the UK and other more low prevalence areas, it's usually spread among adults as a result of sexual transmission or injecting drug use. Majority of adults who get hepatitis B will go on to have a short illness, and only 5% will go on to develop chronic hepatitis. We'll have a look at hepatitis C, and similar sort of in terms of prevalence. Here we're looking at higher prevalence of over 3%, and you're looking particularly at areas of Africa. The most high prevalence area in the world is Egypt, and that has a prevalence around 14% hepatitis C. And that's because, unfortunately, of a schistosomiasis campaign that ran over many years where they reuse needles. Unfortunately, that's made it endemic in that country. In large parts of Asia, again, there's sort of a moderate prevalence. And again, in most of the US and Europe, there's a low prevalence of hepatitis C. But there are certain populations within low prevalence areas who have higher prevalence of hepatitis C. And that particularly affects, in the UK, injecting drug users and also migrants. So it's estimated that worldwide there's around 170 million people infected by chronic hepatitis C, up to 400,000 in the UK. But again, we haven't found most of them yet. And the overall prevalence is about 0.6%. Now, it's nearly always by percutaneous contact, and in developing countries, that's usually iatrogenic. For instance, we've done a lot of work looking at Pakistanis with hepatitis C, and in Pakistan, the average number of injections per person per year is 8 to 12. That's medical injections per person per year, and 96% of those are felt to be unnecessary. So there's a real problem within the healthcare system of using needles. Often needles are reused, and up to 25% of blood products are not screened for hepatitis C. So this is why it's such a problem with iatrogenic use. The other thing that can also affect people is dental work, and also the cutthroat barbers on streets who often don't sterilise their things properly. In the UK, as I mentioned, and other developed countries, it's usually injection drug use. There's a prevalence of around 60 to 90% of hepatitis C. Just looking at migrants in the UK and why we're particularly interested in, they have much higher prevalences. So if you come from a high prevalence country, you bring some of that high prevalence with you. So in Pakistani and Somali migrants, there's prevalences of nearly 2% and nearly 6% for hepatitis B. In Polish migrants, prevalence of 10%, hepatitis C, and also in Pakistani migrants about 2.7%. Around the Olympics, we had an increase in hepatitis C in East London because of lots of workers coming over from Eastern Europe to help build the Olympic stadiums. So it's interesting how just short-term dynamics can affect how things affects our local population. Interestingly, the Health Protection Authority estimates that 90% of new chronic infections of hepatitis B per year occur in migrants. That's because the majority of migrants will have caught hepatitis B when they were children from their mother, and therefore they develop chronic infection, whereas those in the UK will develop it mostly clear. So it's estimated there's probably around 50,000 migrants in the UK who have hepatitis B or hepatitis C. So it is a significant problem, and particularly for those of us who work in areas where there are a lot of migrants. We're interested, I work at the Royal London Hospital, and in the borough of Newham, 38% of people who live in there currently were born abroad, and probably about 50-60% of those were born in Asia or Africa, so high prevalence areas of hepatitis B and C. So we have a particular interest, and it very much depends on your local demography. I assume because you're all here, you're interested in migrants and have presumably quite large migrant populations within your surgeries. I wanted to talk very briefly about hepatitis B and C and their diagnosis, mainly because it's something that confuses a lot of people, myself before I started doing it, but just to look at what we should be taking in terms of blood tests and also what happens to the migrants. So this is the typical pattern of infection for someone who gets hepatitis B when they're a child. And what they'll do is they'll have a very high replicative phase with very high HBV DNA levels and ALT levels that are moderate. They'll be HBs antigen positive the whole time. They will then clear the HBe antigen. At this point, they will have high levels of ALT and the hepatitis B virus DNA will settle down. This is a period during which they have lots and lots of chronic inflammation and they're at risk of developing cirrhosis in the liver. And you would diagnose that by the fact that they're hepatitis B e antigen positive with positive hepatitis B surface antigen, raised levels of ALT and hepatitis B virus DNA that's moderately high. Then most of the patients that you'll probably see are ones that are in the chronic inactive phase, and people are often unsure as to what to do with them and whether they should be referred or not. This is people who are here in the non-replicative phase. So these are patients who have converted their hepatitis B e antigen to anti-HBe, their DNA levels are low, and their ALT levels are low. They're normally asymptomatic. These are patients who don't require treatment, but we still want them all to be referred up to us in the hepatology clinics because around 20 to 30% of them will reactivate and will start to develop chronic hepatitis B. So they'll develop hepatitis B e antigen chronic hepatitis. So this means that their DNA levels will increase and their ALT levels will increase. And you can normally pick these patients up by the fact they'll have an ALT above the upper limit of normal and the HBV DNA will be over 2,000. So when this happens, we usually need to start treatments, but we like to monitor them during this phase to see whether they are developing hepatitis B e antigen negative hepatitis. The majority of patients do not have any symptoms when they have hepatitis B. So we have to actually try to diagnose them purely on risk factors, the ones that we've been talking about already. So people who get it in childhood are generally completely asymptomatic, and only 50% of adults will get any form of symptoms. This is just looking at the diagnosis of hepatitis C. Hepatitis C, in about 15% of people, will just be an acute injury. So what will happen is 80% of people will have no symptoms whatsoever with hepatitis C. But if they do, they may get jaundice, right upper quadrant pain. They'll have very high levels of hepatitis C RNA, and their serum transaminases will also go up. But in 15% of people, their hepatitis C RNA goes down to negative, and they develop antibodies to hepatitis C. So they'll have proof of previous exposure, so they'll have a positive hepatitis C virus antibody. In 85% of people, they go on to develop chronic hepatitis. So the vast majority infected with hepatitis C will. So they'll have their acute disease, which will be similar with high levels of hepatitis C virus RNA and also high levels of serum transaminases, but then they will have persistently high levels of hepatitis C virus RNA, and that's the crucial thing for diagnosing ongoing hepatitis C. Again, why we think that this is important in terms of ascertainment and screening, why we should be screening people, is because they're largely silent diseases. It's been estimated in Europe only up to a maximum 40% of patients with hepatitis C have actually been diagnosed. It's been estimated recently that 165,000 people in the UK have hepatitis C and are unaware of their infections, and that possibly 80% of those with hepatitis B are also unaware of their infections. So the only way we can pick up these people is if we screen them based on their risk factors. We've covered a little bit of this, so I'll go through this, but just to, again, sort of say why this is so important. I'm sure you're all aware of the consequences of chronic hepatitis, but we looked at it before. So perinatal infection, about 90% of patients will go on to develop chronic infection. In childhood, 30%, and in adulthood, less than 5%. From this point, they will either develop chronic hepatitis B virus or they'll be in the inactive carrier state. But as can be seen, they can go back and forwards from that during this. Then 2 to 10% per year, and probably 40% overall of patients with chronic hepatitis B will go on to develop cirrhosis. So quite a significant proportion of those patients that you may see with this chronic hepatitis B. And then 3 and 2% per year of those go on to develop decompensation or hepatocellular carcinoma, both of which have a very poor outcome. So the reason it's really important is we need to pick up these patients who we can then treat. And it's been estimated that by treating patients, you can reduce their risk of cirrhosis and decompensation by about 80% with hepatitis B. We'll go a little bit more into the treatment in a minute. So there really is something that we can do about this. Hepatitis C, we've gone through this a little bit, but 85% will go on to develop chronic infection. A large proportion of those will remain stable, but a significant percentage, around 20%, will then go on to develop cirrhosis. Some of those are slowly progressive, that can be over 30 or 40 years, and others are more quickly progressive, particularly if they are co-infected with HIV or they drink heavily with alcohol. And about 25% of those will go on to develop hepatitis C carcinoma or will die from their liver disease. Just another thing to underline the sort of adverse effects of having chronic hepatitis B or C. Over recent years, since 1998 and coming up to 2010, this is looking at hospitalisations with end-stage liver disease or hepatocellular carcinoma in the UK. And as you can see, there's been unfortunately an inexorable rise. This may well be related to the fact that a lot of patients who got hepatitis C, particularly from injection drug use, got it in the 1980s, and it usually takes about 20 to 30 years before they develop cirrhosis. So that might be why we're now suddenly seeing this explosion. And it's been described as a viral time bomb. Okay. And again, why it's really important in migrants, because they appear to have much higher morbidity and mortality related to hepatitis B and C. So there has been studies that have basically showed that the rates of end-stage liver disease in Pakistani and Bangladeshi men are 7 to 10 times higher than would be expected in Caucasian men of a similar age and matched. And again, hepatocellular carcinoma rates are much, much higher. There's been a study that's been done that basically showed in age-matched Caucasian and Asian patients, the Caucasian patients had a 25% rate of cirrhosis versus elderly Asian patients who had 78% rate of cirrhosis. This was with hepatitis C. It's felt that this is probably related to, when they looked at the factors, the longer duration of infection. That's probably the only factor that seems to make a difference. There's also been some work that's shown higher standardised mortality ratios in migrant men from Africa and Asia who have cirrhosis of the liver generally. So these are people who appear to get significantly more problems and a greater risk of end-stage liver disease than others. Just very briefly going to look at treatment. So with hepatitis B virus, I'm not going to go into details, but we can treat with either pegylated interferon or the nucleoside and nucleotide antagonists. You probably have a few patients who are taking entecavir or possibly nalofudine or tenofovir. Over 90% of patients can achieve viral suppression. We can't cure hepatitis B in most of these patients with the nucleotide antagonist, but we can virally suppress them, which stops their rate of progression to cirrhosis and also to end-stage liver disease, so really improves things. And with hepatitis C, we treat them with 24 or 48 weeks of pegylated interferon or ribavirin. And at the moment, we can get a cure rate, a sustained viral response between 40 and 80%, but we've got a whole new generation of drugs, the new direct-acting antivirals, that are just on the horizon that look like they're going to significantly improve those cure rates. So they're very treatable diseases. This is just the sort of patients that we want to treat. With hepatitis B, we're looking at patients who have basically got evidence of liver damage and evidence of chronic ongoing hepatitis, so that chronic e-antigen negative hepatitis. So we're looking at, they've got raised HBV DNA levels, raised ALT, and if they have cirrhosis and any level of detectable HBV DNA, we'd want to treat them. Hepatitis C, once you have evidence of chronic hepatitis C, NICE is approved treatment for all patients who have evidence of chronic hepatitis C. So, I've already been going over this point, but why should we screen migrants? We basically have very low current ascertainment rates. There is a significant morbidity and mortality related to hepatitis B and C, particularly in migrants, and it has the potential to be a significant public health problem. There's also been modelling studies that show not only can we improve the outcome for the individual with hepatitis B and C, but we can also reduce onward transmission of hepatitis B and C by screening and then treating patients. I'm just going to tell you a little bit about some research we did. Pilot screening study in primary care, where we basically looked at 2 different methods of screening. We did this in the borough of Newham. We had 5 different GP practices involved, one of which did an opportunistic screening. The opportunistic screening was where every patient who came from Pakistan or was of British Pakistani origin was offered screening by their GP or by their practice nurse whenever they came for anything, any other thing, their blood pressure checks, anything. The reason why we chose people of Pakistani origin was because we'd done a previous MOS screening study showing that they had rates of 1.8% hepatitis B and 2.7% hepatitis C within that area. So we knew that they were high prevalence. And also there's a large Pakistani population. Our opt-out screening arm was in 4 GP practices with a similar number of about 1,000 patients, and that was where research fellows basically contacted every patient by letter and then by phone to see whether they'd be interested in attending screening clinics for hepatitis B and hepatitis C. It was a pilot study, so it wasn't great numbers, but these were the results. In the opportunistic arm, 1.4% of patients who were from Pakistan were screened. So that was 17 patients out of a total of 1,163. In the opt-out arm, about 20% of patients were screened. So what this showed us is it's quite difficult to screen patients and get them involved. If you target them directly, it appears to be more effective. This line here is patients that we could contact. We couldn't contact nearly half the patients to bring them in for screening. And that was due to sometimes patients not being in, telephone numbers not being correct, sometimes language difficulties. And we managed to screen 37% of people that we actually spoke to. So still quite difficult. Out of those, there was nobody who tested positive of the 17 who were done in the opt-out arm, but of the research fellow arm, basically we had about a 1% hepatitis B positivity rate and a 2% hepatitis C positivity rate, so similar to our previous findings. Okay, so I'm just going to run through sort of what the current recommendations are and what we hope that you'll do if you're interested. What's the best way for screening? Well, in GP practices, we're sure is the best way to do it. Probably a targeted approach, and there's a very, very large study that's just about to start that will look into this in a bit more detail. Culturally targeted approaches appear to be more effective. There's been studies in the US and various other countries looking at specific targeted populations, and it appears to work better if you get, for instance, with the Muslim community, mosques involved, in the Chinese community, if you can get Chinese local community centres involved, and just increase the information that patients are given, because the main reasons for patients not actually getting involved in screenings, they perceive themselves to be at low risk and they don't have much information about hepatitis B and C and the harms it may cause. In terms of government recommendations, there's currently draft NICE public health guidance that's gone out for consultation that's looking at recommending screening for all at-risk patients for hepatitis B and C, and that includes migrants from areas of over 2% prevalence. And back in 2008, as hepatitis C was coming onto the political agenda, the Chief Medical Officer, I'm sure you know, wrote to all GP surgeries as part of the Face It campaign, asking GPs to screen anybody who felt was at risk of hepatitis. This included injecting drug users, but also patients from countries of high prevalence. So who are we screening? Patients from countries of over 2% prevalence of hepatitis B or C. That includes, you can get this information actually off the HPA website, but China, most of Southeast Asia and the Pacific, most of Africa, and countries in Eastern Europe and South Asia. In terms of testing, I was interested in the HIV testing, you can do direct screening, but at the moment we're still doing hepatitis B surface antigen serum tests and hepatitis C virus antibody serum tests for screening. There are direct acting tests for hepatitis C at the moment, but they're not widely used. If they're hepatitis B surface antigen positive, please refer them all up to secondary care, because as I was discussing earlier, there is a risk, even if they're currently in the inactive chronic carrier state, that they may reactivate. As you all know, and you're much better at the public health aspect, I think, than we are, you should test all household contacts and advise on reduction of onward transmission. Vaccination should be offered to all patients who test negative and all of their family members as well, and also their children. And babies with hepatitis B virus positive women who are at risk, which essentially is supposed to be anyone who's HBs antigen positive, particularly if they're E antigen positive, should be offered immunoglobulin. That should happen naturally through screening, and you should inform the health protection unit, who should contact the cases contacts themselves. If they're hepatitis C virus antibody positive, what you should do is to confirm it on a second sample and then perform a HCV RNA. And if the hepatitis C virus RNA is positive, they have chronic viral hepatitis, so they should be referred up to secondary care again. You should also advise them on reduction of alcohol, and also smoking can progress that, and also consider testing other family members and inform the health protection unit. If they're HCV RNA negative but you have a high index of suspicion that they might have hepatitis C, then you can perform a second HCV RNA test in 4 to 6 weeks. It normally indicates previously resolved infection, but it's always worth rechecking as the levels can go up and down, sometimes below the lower limit of normal of detection. And if they're hepatitis C virus antibody negative but high suspicion, then repeat the hepatitis C virus antibody in 3 months' time. So, in conclusion, these are important public health problems, particularly affect migrants, and are treatable in the majority of cases. So we should be trying to screen people who are at risk, and if they are positive, referring them on to secondary care to see if they're suitable for treatment. And that's it. Any questions?